Welcome to Chapter 13, Pediatric Hearing Loss. The beginning of the chapter summarizes just the sense of hearing in general, calling it miraculous. I'm saying the ear contains the smallest bones in the human body and has specialized sensory cells that can process sounds ranging from the drop of a pin to the takeoff of an airplane. The human ear can also perceive minute changes in pitch and loudness, recognize a familiar voice on the phone, and differentiate among the many sounds at an amusement park. In short, hearing links us to the world around us. When an individual's hearing is diminished or lost because of injury, illness, or even genetics, the results are life-altering. Specifically looking at pediatric hearing loss, is referring to a condition in which a child or adolescent is unable to detect or distinguish the range of sounds normally available to the human ear. Hearing loss affects the outer ear or the inner ear. We'll talk about that a little bit more specifically in a few minutes. Auditory processing disorder, known as APD, is a hearing loss resulting from brain damage to the processing centers of the brain. And it actually, in reality, it's not necessarily a hearing loss as we think about it, but it is damage to the processing centers of the brain. Hearing loss among children is highly variable. Looking at different aspects of that, the location of the damage to the hearing structures is looked at. Because we have two ears, hearing loss varies in whether it affects one or both ears. Obviously, a bilateral hearing loss is going to affect somebody's hearing more than a unilateral hearing loss or a hearing loss in one ear. The extent of which hearing acuity is impacted by congenital hearing loss, a prelingual hearing loss, or a postlingual hearing loss. Congenital obviously being from birth, prelingual being prior to a child learning language, and postlingual being after a child learns language. And there are several terms used when describing hearing loss: hearing impairment, hearing disorder, deafness, hard of hearing, hearing loss, deaf with a capital D, and the deaf community. And our book refers to hearing loss as being acceptable terminology, and also hard of hearing, mainly because if you're saying a hearing loss, you're saying exactly what it is, a loss of hearing, and you're not referring to it as any type of a disorder or any type of an impairment. The capital D deaf community, or someone who is capital D deaf, looks at deafness and hearing loss as though they don't look at it as a disability. They just look at it as another way of life, another way of communicating through the use of typically ASL or American Sign Language. The reported prevalence of hearing loss among children varies significantly depending on the criteria used to identify the loss. Educationally significant refers to a hearing loss that is serious enough to impact a child's ability to perform well educationally. Integration into the community, the hearing community, that is, will be looked at. The deaf community, we talked about a little bit a minute ago, which is the community of people who are hard of hearing or who are deaf, and how they relate to each other within that deaf community, and then the communication development overall of somebody who is deaf. Hearing loss in children and adolescents is typically classified according to etiology, its manifestation and impact, and its severity. genetic or environmental cause, which is it, a genetic or an environmental cause, or and looking also at age of onset and the type of loss, which, like I said before, we'll be talking about in just a little bit. Genetic and environmental factors that can result in hearing loss are numerous. In many cases, the specific cause is unknown. Autosomal dominant hearing loss is where one parent has a hearing loss and is a carrier of a dominant gene for hearing loss, which is then passed on to a child. The child then has a 50% chance of having a genetic hearing loss. And then autosomal recessive hearing loss. Both parents carry a recessive trait for hearing loss, but neither of the parents have a hearing loss. Their child has a 25% chance of a congenital hearing loss, which, if it does occur, may be unknown or a surprise to the parents who are hearing. Looking at the age of onset for hearing loss is typically differentiated into developmental or acquired categories. Developmental is present at birth. Acquired is going to occur sometime after birth. Prelingual is the loss occurring before language is acquired, and postlingual, the loss occurring after language is acquired. And then looking at the different types of hearing loss, these identify the auditory structures that are affected. The three different types of hearing loss include conductive, sensory neural, and mixed. We'll look at each of those a little bit closer on the next couple of slides. In classifying hearing loss of a given individual, experts consider all of these sources of information: the cause of loss, age of onset, and the type of loss. Some children with hearing loss experience loss of hearing acuity, referring to the precision of hearing at different levels of loudness. More problematic than a loss in acuity is a decrease in auditory comprehension of spoken language and speech perception, which can accompany hearing loss. Severity of hearing loss is also classified according to its hearing loss is also classified according to its severity using the decibel system. And decibel, Alexander Graham Bell, the BEL at the end of that word. Decibels are standard units of sound intensity. They represent the differences in loudness available to human hearing from the threshold of sound at 0 dB, which doesn't mean no sound. It just means the lowest level of sound that a human can possibly hear. And an example of that would be the drop of a pin, to the threshold of pain between 120 and 140 decibels. A fire alarm close to your ear would be painful. There are different categories of the decibels to categorize different types of hearing loss. Minimal hearing loss would be 16 to 25 decibels. A mild loss would be 26 to 40. A moderate hearing loss would be 41 to 55 decibels. And a moderately severe would be 56 to 70 decibels. Severe hearing loss would be 71 to 90 decibels, and a profound hearing loss would be 91 decibels or higher. And you may hear decibels referred to as dB for short. The threshold of hearing is plotted on a graph called an audiogram, and we'll be looking at one audiogram in just a minute. Oh, right now. So looking at this audiogram, you can see the red line going across at 20 dBs or 20 decibels, and that's the hearing level. That 20 decibel, or above that 20 rather, you can see where the normal hearing is depicted to the right with the arrows from that -10 to 20. And then you can see to the left going from quiet to loudness. So obviously, as the numbers increase, the loudness increases. The frequencies are indicated across the bottom from 125 to 8,000, looking at the speech frequencies of a talking voice, kind of in the middle of that audiogram. 500, 1,000, 2,000. I'm sorry, 1,000, 2,000, 4,000. Kind of where the dotted lines are going vertically through sort of the middle of that audiogram. Here is another audiogram. You can see what's referred to as the speech banana, kind of going through the middle of that audiogram and kind of showing you where different sounds from a speaking voice are produced within that speech banana, and then depicting different types of sounds like a dog barking, a lawnmower, a jackhammer, the telephone ringing, all within the ranges that those are heard. Then looking at the three types of hearing loss: conductive, sensory neural, and mixed. We'll look at those one at a time. A conductive hearing loss is when sound is not conducted efficiently through the outer or middle ear. The result is an attenuating or reduction of the sound that's heard. Children who have a conductive hearing loss, whether it's temporary or persistent, experience this attenuation of loudness. And oftentimes when we think about a conductive hearing loss or a hearing loss that is not permanent, we think about children who have ear infections where fluid is filling the middle ear, and children might have a mild hearing loss while that hearing loss is clearing up. So they might be hearing speech sound kind of garbled during that time, but it is something that's going to resolve once the infection is cleared up. Bone conduction is the transmitting of sound vibrations along the bones of the skull. If you think about when you're chewing a piece of gum and it sounds like it's loud, bone conduction is the reason for that, because it actually is the vibration of those bones that you're using to chew. Causes and risk factors of conductive hearing loss. Like we just talked about, the otitis media, otherwise known as an ear infection. Children will frequently experience conductive hearing loss along with the ear infection, and it usually can be reversed. The wax builds up and blocks the sound transmission. Then looking at a sensory neural hearing loss. This is the most common type of hearing loss resulting from damage to the cochlea, or the auditory nerve that travels from the cochlea to the brain. Even though sensory neural disorders are thought of as a decrease in overall loudness, they're also associated with a decrease in speech perception and a decreased ability to distinguish speech from background noise. Some of the causes and risk factors. Most often, sensory neural hearing loss is present at birth as a congenital hearing loss, so it's not too common for that to be acquired later on in life. It'll be present at birth. Some of the greatest risks include serious illness, drug use, other problems of the mother during pregnancy, in utero infections, including the cytomegalovirus, herpes, toxoplasmosis, syphilis, and rubella. In known cases of the cause of deafness, genetics and heredity can play a part, can be pregnancy related or post-birth disease or injury. Then looking at mixed hearing loss. When a person experiences both conductive and sensory neural loss, it's referred to as a mixed loss. For For example, a child with a congenital sensorineural hearing loss may also acquire a conductive hearing loss from a bout of otitis media, or because of wax buildup in the ear. Then a mixed hearing loss typically includes a permanent reduction of sound, which is the sensorineural component, as well as additional temporary loss of hearing from the conductive component, which would be the ear infection. So assessment for hearing loss in pediatric population requires a multi-tiered approach. There's an assessment process similar to the other types of disorders that we've looked at throughout the book. And of course, accurate diagnosis is important. The referral or the assessment process begins, like most of the other assessment processes we've looked at, with the referral. And then goes on to the screening and comprehensive audiological evaluation, and if necessary, a hearing aid evaluation. Looking at those a little bit more individually, the referral, early diagnosis of hearing impairment programs are present in most states. Their goal is to detect hearing loss at birth while the infant is still in the hospital. So in the toddler and preschool years, children who exhibit developmental delays in communication, who have a hereditary predisposition to hearing loss, or who develop diseases or disorders that impact the auditory mechanism, should be referred for a hearing screening or an evaluation. So screening usually falls into two categories: an infant screening and conventional hearing screenings, depending on the child's age. The infant hearing screenings are also called newborn hearing screenings. They're completed at birth and involve specialized testing that's typically completed before a newborn leaves the hospital. If you know of anybody, or if you yourself have had a child, most likely someone at the time of the birth will refer to, oh, they passed their newborn hearing screening. Let me back up just a minute. The conventional hearing screenings, depending on the child's age, are referring to screenings that are done typically in the school system in first, third, and fifth grades. Children, kind of like a mass hearing screening, where children will come in and just raise their hand to a series of beeps to make sure that that child is indeed hearing. And if not, then a comprehensive audiological evaluation might be recommended. A comprehensive evaluation assesses the type and degree of hearing loss, speech discrimination, and auditory perception abilities in quiet and noisy conditions, and any other concerns. Case history would then be completed as the first step in a comprehensive audiological evaluation. A parent or primary caregiver will complete the case history form and possibly an interview with the clinician. These are important for uncovering further concerns or behaviors related to auditory problems, and will help the clinician to determine the primary reason for the referral. An interview and an observation is a useful way to obtain parental input about a child's auditory and communicative behaviors. A variety of tools are available to use. Auditory behavior in everyday life is something that might be used, completed by the parents, and provides information concerning auditory behaviors. Observations can also be used to understand strengths and needs in different contexts. You might observe the following in a child's classroom setting: listening demands in the classroom, a teacher and student speaking behaviors, and level of noise in the classroom. Then an otoscopic examination. The purpose of this would be to detect any abnormalities in the structures and to ensure a clear external auditory canal prior to testing. So it's an important tool for studying the characteristics of the tympanic membrane. It can reveal whether there's negative pressure behind the membrane, whether the middle ear is inflamed, and whether there is fluid in the middle ear. Then the next part of the audiological evaluation would be audiometry. It's also called pure tone testing. And if you have ever had this done, you might remember going into a sound booth and having headphones being put on your head, and the audiologist will be on the other side of the sound booth, most likely, and will be putting some sounds and maybe even some words into your ears, and you'll be responding by possibly pushing a button, raising a hand, dropping a block into a bucket. This is called play audiometry, and is often used with younger children. Appears to be kind of like a game-like situation, and they'll be taught or conditioned to put a colorful peg in a pegboard or drop a block in a bucket when they hear a sound. So of course they're going to be hopefully enjoying the game that's been set up for them, and the audiologist will be able to obtain pure tone testing through that means. And then other objective measures may also be used. Some of those would be tympanometry, otoacoustic emissions, evoked auditory potentials, might be used by the audiologist, and those are described more completely in your book on page 461. Next, if necessary, an audiologist who identifies a hearing loss in a child works with the child and the child's family to determine the most appropriate avenue for habilitation. And at this point, talk of a hearing aid might be introduced through probe microphone measurement or electroacoustic evaluation to see what is the most appropriate type of hearing aid for the child. Hearing loss is an invisible disorder. There's typically no outward physical sign that a problem exists. So this might complicate identification and treatment of hearing loss among children of all ages. Sometimes a false positive might occur where a test shows that there is a hearing loss, but in fact there's really not. Or the opposite of that, a false negative might occur where the test shows that there's not a hearing loss, but indeed there really is. So obviously, looking for accurate diagnosis is important in being able to then treat somebody with a hearing loss. And looking at how pediatric hearing loss is treated once it's diagnosed, be looking at different communication choices, amplification and listening devices, oral habilitation, intervention principles for infants, toddlers, and preschoolers, and intervention principles for school-age children. Looking a little bit closer at each of those communication choices. So the overall goal of all interventions for pediatric hearing loss is the development of healthy, socially and emotionally balanced children who are able to integrate fully into society and lead productive lives. And in the book on page 462 talks a little bit about the capital D deaf versus the lowercase d deaf. And the capital D deaf refers to the deaf community, which really is a community that functions within the larger mainstream oral community, and their general approach to life is a little bit different. They feel like that deafness is not a disability, and that their capability depends on their own sense of identity and the way they relate to the world around them. Sometimes there's a combination of both fitting into both communities, where it's the deaf community where you're just immersing yourself with other people who use American Sign Language, and then versus just the deaf community overall, where maybe total communication might be used, where oral communication and American Sign Language might be used. Amplification and listening devices. Many children with mild to severe hearing loss are fitted with amplification devices. Data from Gallaudet Research Institute shows that 59% of students and youth with hearing loss use hearing aids for instructional purposes. Hearing aids, assistive listening devices, and cochlear implants all would be under this category of amplification and listening devices. With hearing aids, they're available in many styles, and children are typically fitted with behind the ear hearing aids rather than in the ear hearing aids, because adults mainly use those because of a small size and cosmetic appeal. The ear molds are custom made for each child from silicone or a similar material. The ear molds, tubing, and hearing aid all help to shape the sound as it enters the ear. And then looking at assistive listening devices. The most commonly used assistive listening device, or ALD, is called an FM system. It's a personal amplification system that can be used independently or with a hearing aid. It's helpful in both noisy situations and with distant speakers or signals. You may have seen somebody in maybe even in your own class or in another class in elementary or middle or high school who was using an FM system. And typically the speaker or the teacher, in most cases, in a school setting, would wear a small microphone that transmits to the listener's device or the receiver. The receiver can be something that's like a necklace looking like a pen hanging down from it, or it can be a desktop speaker that the child puts just in the corner of their desk to amplify the sound coming from the teacher's microphone. And then cochlear implants are surgically placed devices that provide direct electrical stimulation to the auditory nerve. These are appropriate for children who have severe to profound sensory neural hearing loss. More than 10,000 children have received cochlear implants worldwide, and there's still a lot of research going on to make cochlear implants more effective. In a nutshell, they're a computerized device that allows people with severe to profound sensory neural hearing loss to detect sound. The device works by directly stimulating the auditory nerve with electrical signals, bypassing damaged hair cells of the cochlea. The external portion, which sits behind the ear, houses the microphone, speech processor, and transmitter. The internal portion includes the receiver and electrodes. The microphone picks up sound and sends it to the speech processor, which analyzes and digitizes the sound. And the transmitter then sends the information to the receiver, which converts the coded speech signals to electrical signals, which are then sent to the electrodes. Cochlear implants might be implanted in one ear with a hearing aid used in another ear, or it might be implanted in both ears. Extensive testing is required before a child can be approved for cochlear implant surgery. Many factors are considered before this surgery is approved. Oral rehabilitation, hearing loss among children and adolescents requires individualized intervention. Goals, looking at ensuring an appropriate listening environment, maximizing audition, and supporting listening development will these kinds of goals will all be implemented with the child. Intervention principles for infants, toddlers, and preschoolers. Early intervention is key in helping to develop strategies for working with infants and toddlers and preschoolers. Parental involvement is a must, as much as an audiologist or a speech language pathologist would like to think that they can go in and wave a magic wand and make things better in a couple of, hour-long sessions a week. In reality, this is just not the case. Parents need to be extremely involved in learning strategies and then implementing those strategies that they've learned from an audiologist or a speech language pathologist with their child on a daily basis. And using these strategies and intervention methods in naturalistic environments is going to be optimal for the child, because those are the environments that they're going to be learning in. Social interaction is very important for these children, so that they can, develop a support base with peers. Children learn a lot from their peers, and this is also the case with children who are hearing impaired or have hearing loss. Functional outcomes. You're going to, if you go in with a family and discuss intervention strategies, and you have outcomes that are not going to be functional and are not going to be things that the family can implement on a daily basis, then it's not going to be helpful to the family. Outcomes need to be functional and need to be things that the parents can grasp onto from watching a speech pathologist or an audiologist perform in a session. And they also need to be strategies that parents can understand and that children can also learn from the parent. If they're too involved or too stressful for either the parent or the child, chances are those intervention strategies are not going to be implemented on a daily basis by the family. For school-age children who are diagnosed with an acquired hearing loss or an undetected congenital loss, who have established audition and speech and language skills, there are intervention principles that can be put in place to make sure that there is an effective means of communication. And then you will be looking at if a child has an inadequate oral communication, if the child is an inadequate oral communicator, parents need to consider enhancing communication with sign language or finding a way to improve audition, such as with cochlear implantation. A child who's taught sign language must have the support of family and friends, and families need to be able to foster the development of relationship with peers who have the same language, such as ASL, if the children are not naturally involved in activities or experiences with other children with whom they can communicate. Then self-advocacy. Children with hearing loss often have special needs in respect to their communication, particularly outside the home. They may need to request clarity or assistance in class. They may need instructions repeated or written down. They may need an interpreter to help them with schoolwork. Participating in a sporting event might require assistance of technology to enable the athlete to hear the coach from a distance. And all of those things are important things to be taught to children once they are school age, so that they can advocate for themselves when they're out in public, away from home, without a parent or possibly even a teacher to advocate for them. And then looking at literacy, in this case, we're talking about more than reading and writing. It also includes thoughts, or the ability to think critically and reflectively and to use language to solve problems and reason. Children who have hearing loss often exhibit weaknesses in their language base, and so therefore literacy is often compromised. The importance of literacy for children with hearing loss goes well beyond access. Reading provides children with an alternative avenue to improving language. Obviously, you don't have to hear to be able to read. So vocabulary, spelling, and other academic skills can be developed through reading. Looking at auditory processing disorder, it's a type of hearing loss that adversely affects an individual's processing or interpretation of auditory messages. An individual with APD has problems in one or more of the following aspects of auditory processing. They may have difficulty with sound localization and lateralization with both ears, with auditory discrimination, such as hearing the difference between different sounds, recognition of patterns of sound, differentiation of the temporal aspects of sound, auditory performance when a message is incomplete or when competing acoustic signals are present. Defining characteristics of APD, it's a neurological problem in which a child has difficulty interpreting and processing auditory information, even though hearing acuity is intact. Common indicators, the child might behave as if a hearing loss is present, although it's not. The child may show problems following complex multi-step directions. The child may exhibit difficulties with reading and spelling performance, or reveal degraded listening and audition in noisy environments or with competing auditory stimuli. They may appear to seek out visual cues from the environment. They might have a history of fluctuating hearing loss, including middle ear infections, or have difficulty staying on task, finishing assignments, and working independently. Obviously, more than one of these indicators would need to be present in order to have a diagnosis of APD. Scientists do not fully understand the underlying process of the auditory processing mechanisms or the ways they malfunction to result in communication disorders. Consequently, the specific cause of APD is unknown. In assessment, there's currently no gold standard for identifying the presence of an APD, although an audiologist does have a set of tools to study auditory processing capabilities. The assessment tasks examine sensitivity to the temporal ordering of sounds, the ability to listen to sounds when they are degraded or have other sounds competing, and the ability to listen to different stimuli in both ears simultaneously. Treatment approaches for APD focus on reducing the symptoms of the disorder, and the most common symptoms cluster into 4 areas of concern. And those areas include behaviors, literacy, linguistic ability, and organization. And that's the end of the lecture for Chapter 13, Pediatric Hearing Loss. Thanks for listening. Be sure to read the text for Chapter 13 as it goes much more in depth than the lecture does on all of the components that were touched upon during this lecture.